Dr. Frank, welcome to Melbourne. I hope you've enjoyed your time at the 11th National Prostate Cancer Symposium.
It's been fantastic.
Thank you for joining us.
Thank you.
Dr. Frank, what made you direct your career in urology towards the treatment of prostate cancer?
Well, during my training, I saw that patients that were diagnosed with prostate cancer were faced with a myriad of treatment options. And when I looked at the different potential options that patients had, I found that there were several different good options that provided high cure rates and several good options that provided excellent quality of life. And one of those options was radiation therapy. And it provided me an opportunity to explore that in patients, especially when 1 out of 6 men in the United States are currently being diagnosed with that annually.
Would you say that the technological improvements so far in radiotherapy have been mainly to improve cancer outcomes or just decrease the side effects of radiation therapy?
Yeah, I would say that we both. And the reason it's both is because by utilizing imaging, targeting, image guidance, and delivery, we're able to more appropriately actually hit the cancer, and we are able more appropriately to miss and to stay away from the normal tissue structures.
What do you think is the next big technological step forward in radiation therapy once IMRT gets slightly more outdated?
I think that it's going to revolve around imaging. It's going to revolve around molecular and biomarkers, and it's going to revolve around identifying the exact location of the lesion within the prostate, because currently we are treating the entire prostate, and we have not been focusing our radiation treatment on one specific side or where it's biopsy positive or negative. We are treating the entire gland. And what I believe is going to happen in the future as MR and functional imaging becomes even better, we can then deliver the high doses necessary to sterilize the disease in the tumor site, and then we can treat with lower doses potential microscopic disease that will then provide better quality of life.
From a surgeon's point of view, there are randomized trials of radical prostatectomy versus expectant treatment, which give us urologist statistics when we're counselling patients. What evidence do you base your counselling of patients on when a patient wishes to undergo radiotherapy?
So again, there's different types of treatment, whether it's external or internal. We at MD Anderson have really been the pioneers of dose escalation. We initiated a dose escalation trial back in the 90s, which was the first evidence to suggest that higher doses of radiation will improve patients' outcomes versus lower doses of radiation. The standard doses of radiation have increased from 60 to 70, now up to 80 gray. And what we have seen over that period of time is that there's less local recurrences, there's less nodal recurrences, and there's less distant recurrences. And so by incorporating higher doses to the prostate and to the cancer, we've been able systematically through a randomized trial to evaluate and see the advantage and effectiveness of radiation therapy alone.
Studies have demonstrated that high-risk localized prostate cancer can be treated with radiotherapy, but hormones improve outcomes. Do you think that this is just a PSA response to the hormones, or do you think there is an overall improvement in cancer-specific mortality?
There have been a number of randomized trials. There's been 4 specifically in the last several decades, starting with the radiation therapy oncology group back in 1985. Yeah. There have been additional trials, 1986 and 1992. There's the EORTC trial, all that have been utilized radiation therapy in conjunction with hormone therapy or radiation therapy alone. And in those studies, there is clear evidence that there is a survival benefit by utilizing hormone therapy with radiation in those settings. Some of the major questions that have arisen is that in the current day of dose escalation, how much hormone therapy is necessary.
And for how long.
And for how long. And so the duration of that hormone therapy comes with its own set of side effects. And if we can shorten that duration and provide equivalent survival benefit, then I think that we will improve patients' quality of life as well.
You published previously that prostate nomograms can be fallible, and when used in your institution, actually gave a poor prediction of survival outcome compared to your own institution's data, which was superior. It is often difficult to give patients hard data regarding the outcomes of various treatments in prostate cancer without referring to a nomogram. Can you see a way of improving on this situation? And do you think nomograms can be improved to become more accurate in reflecting the cancer outcomes for patients out there?
I do think that nomograms are important tools. I think that they have to be updated. They have to be updated to reflect modern outcomes. And I think that it is confusing and difficult for patients who are diagnosed with prostate cancer to try to make a decision about what their treatment options are going to be when first and foremost they might want to be cured. And then they look at quality of life. From the data from our institution, we have done a multi-institutional, multinational study to further determine if the evidence in which we saw within our own group was consistent on a national and international basis. That work was done with the Utrecht Medical Center, with Princess Margaret, and with the Seattle Prostate Institute. And what we basically have concurred and found in that data set is that over half of the predicted failures are not failures at all. And the reason for that is because a phenomenon that was not well described at the time of the initial nomogram has been defined over the last decade. And that is that about 50% of men who get brachytherapy subsequently develop a benign PSA bounce. And that benign PSA bounce typically happens in the first, between the 18-month period and the 30-month period following treatment. And so it is not a failure, and in fact there is evidence to suggest that men that have it actually have better outcomes than those that don't. In the future, incorporating nomograms will be important, but we have to have the right potential definition of failure. And one thing that we are looking at is to help define better definitions of what might cause a local or nodal failure or even distant failure following brachytherapy. There is currently another definition that has arisen, but I think the best definition is going to be with a minimum follow-up of patients out to 3 to 4 to 5 years, and then looking at where their PSA is at that point without a consecutive rise. Because once you get out to 4 years, the PSA really should not be bouncing anymore.
It has been said that brachytherapy and surgery for prostate cancer hold a similarity in so much as they are a single curative intervention for localized prostate cancer. I note that the MD Anderson Cancer Center is currently undertaking a trial of interstitial brachytherapy in intermediate risk prostate cancer patients. This is a group of patients often treated with radical surgery. Again, how would you counsel the patient on the relative outcomes of these interventions, despite the paucity of randomized trials out there to answer this?
What we've been basically telling patients is if we look at the guidelines, the standard of care for intermediate risk patients is either surgery, it's external beam radiation plus 6 months of hormone therapy, or a shortened course of external beam radiation plus the addition of a brachytherapy boost.
Yeah.
There is several retrospective studies that have shown that an implant alone may be appropriate for these patients. There's currently a randomized trial going on in the United States looking at external beam radiation therapy followed by the implant or implant alone. We have found that a lot of patients just do not want to be randomized in this day and age. And so what we did at MD Anderson was open up a phase 2 single-arm prospective study looking at 200 patients getting an implant alone for with intermediate risk disease. We have early stopping rules. We have, if there is a recurrence over 15%, and so our predicted goals are to achieve at least a biochemical control rate of 85% at 5 years. And so if we see that there's less than that based on the volume of disease or different disease factors, then we have early stopping rules to protect additional patients.